start first, and then I go over to the patient diagnosis.
Tell me, which one do you want to start with? With the
Maybe, I don't know, can we stop this?
it's okay.
Maybe I'll start talking about complement pathway. Oh, well, actually, you can talk about this. I can start with patient because I guess
You'll start there?
Yeah.
Okay. You tell me. Good. You're in charge. I'm getting out of here. Yeah. All right, welcome everybody. We'll go ahead and get started. This is going to be a joint presentation by myself. I'm Spero Cataland from Ohio State University, and I'm joined with Shreya Agarwal, who I've gotten to know quite well over the past couple of years. She came to Columbus to work with me for several weeks, and it was really, I think, as you'll see, a great experience for both of us and what we were able to do. So these are slides that are general slides meant to trigger discussion. We'll have some discussion along the way, and however, wherever it goes, it's fine with us. This is not going to be a talk about drug development and the details that you don't want to hear about, but we're going to try to talk about, Shreya and I, about kind of how research happens. How do you get from seeing a patient to finding something new that doesn't seem to be described previously? And we'll talk about a little about how drugs are developed and why or why not you might see somebody going after a specific target for a drug. The first thing we're going to talk about is this term thrombotic microangiopathy, TMA. People throw it around a lot. We threw it around the name of our consortium. And why would we pick such a name? You have to remember two things. TMA has a couple different definitions. One of those definitions is a pathology term used by pathologists when they're looking at, in this case, a heart sample, a sample of heart tissue from the very first patient that was diagnosed with TTP. This is a case from Dr. Moskowitz. 1924 is when it was very firstly reported. This is the 100-year anniversary of this being diagnosed for the first time, or wasn't diagnosed or named, but first case that was reported. And unfortunately, she died of this disease. And on the postmortem, where historically these diagnoses were many times made or observations are made, and Dr. Moskowitz clearly recognized that there were clots in the very smallest vessels of this young woman's heart. She was 16 years old when she died from this. So early on, you see clinical descriptions, and unfortunately, you see postmortem descriptions after people have died because there wasn't great testing or understanding of these disorders. So the term TMA, a pathologist will use this to describe what they see on a kidney biopsy. But it's also evolved over the years to reflect a clinical syndrome where a patient has a low platelet count and has fragmented red cells. Now, the reason that happens is when you get those small clots in these arteries like that, red cells rushing past will get torn. And that's where you hear that schistocyte term or fragmented red cells, helmet cells. Any of those terms are going to work. But when you have those clots in the small vessels, you can see this exact thing. The first thing you see is there's no platelets here. You should see platelets. So when a physician looks at the smear, that's one thing they're looking at. But then when you see these red cells here, you start thinking, do I have a disease process where there's small clots happening in the blood vessel for whatever reason? So sometimes doctors will call me and they say, I've got the diagnosis, it's a TMA. And I say, well, that's good. You're just getting started now. You got to figure out what is the cause of it. And we're talking about rare diseases here, right? The atypical HUS, and you're hearing the term complement-mediated TMA. There's an effort in the field to change the naming of the nomenclature, it's called, to reflect what the disease process is. And TMA is the umbrella term under which there are a lot of different things that can do this. Common things like really bad blood pressure can look like this, those fragmented cells and a low platelet count. Infections and severe infections can do this. When you get a really bad infection or other potential causes, you can get something called DIC, which is an expensive name called disseminated intravascular coagulation. It's essentially your clotting system gets turned on and off over and over again, and you use up all of your clotting factors. We're going to show you a case. Shreya is going to show you a case, an evolution of a case that looked just like that. And you try to fit these in these categories, and doctors really want to make sure this isn't TTP because that has a specific treatment with it. They want to make sure it's not, if it's not TTP, is it atypical HUS or complement-mediated TMA? Because those are things that need to be specifically treated. We're also looking for other things clinically. Was there a new medication given? Cancer-associated TMA, metastatic cancer can look just like this. So a lot of things can look like a TMA, but narrowing down what's the cause and what should you be doing about it's important. So far, so good. So just to touch briefly, because you're going to hear talk about TTP. This is an elegant, I think, picture from the late Evan Sadler, who was really a great clinician and a researcher. And what I think this shows very well is what's supposed to happen in the normal body. So this is what's called von Willebrand factor. And this is the glue that sticks your platelets to the vessel wall. This ADAM-TS13 we always talk about, its job and its only job is to cut those pieces from the really big ones to the small ones. The small ones, or I shouldn't say small and normal sized ones, mediate clots where you want it to occur. Injuries at small vessels, cuts at the time of surgery. These big pieces are going to spontaneously start to bind platelets and form clots throughout the body, which is what you see happening down here. This is happening in the smallest blood vessels, the arterioles, we call it. And that's the same where you see some of those clots. So what happens in the small vessels is this VWF is supposed to unfold and then get cut by ADAM-TS13. And when it doesn't happen, that's when you get these big pieces that will bind platelets. So the bottom is what's not supposed to happen. The top is what's supposed to happen. And you can have a low level of ADAM-TS13 because you're born without it in congenital TTP, or you develop an antibody against it. And that antibody can clear it or block its function. So far, so good? So when we're talking about complement-mediated TMA, it's a dysregulation or lack of control of a normal complement system. And understanding just in simple terms what this is, I think will help you understand why people get this disease, why they don't, when they get in trouble, when they might not get into trouble. It's part of the normal immune system. It's thought to be always on, kind of at a low level in the background, trying to identify bacteria, damaged tissue, injured tissue, and sort of doing the housekeeping for the body, protecting the body from bacteria, other pathogens. And when you have dead tissue from an infection or inflammation, it sort of cleans it up. Very powerful system. It will turn on, amplify itself, and then turn off and go away when it's supposed to. That's sort of what's supposed to happen. It's got, and don't worry, there's not going to be a test on this. I barely understand this. These are different pathways. And this is how scientists look at things in a lab to better understand what's happening clinically, but also to identify drugs you can do, areas, I should say, molecules you can target as drugs that'll treat this disease. There's something called the alternative pathway, and that's what we think is the main problem in atypical HUS. There can be genetic variants or mutations in some of these proteins, some of the things that block the complement system. Something called factor H is a powerful brake on the system. So people can get a genetic variant of factor H or an antibody against it, and it's like you don't have it. And so when you get that infection and the system is turned on, you can't turn it off. And that's why AHUS can happen commonly after pregnancy, after infection, after surgery, after any stressor. So the system works fine, if you will. It's the brakes that are the problem. There's a lot of different variants that can do this in the brakes on the system. There's also normal proteins, C3, which is part of these pathways, that can be abnormal. So the brakes work, but the protein itself don't respond to that brake. So there's a lot of different ways that can happen. And you've all heard of eculizumab or Soliris, the first drug treatment. It's a C5 inhibitor, so it works at the bottom. So all these pathways kind of converge in the same place. And that's where eculizumab works, and ravulizumab and some other drugs that are in study. So no matter where the problem is, the brakes are on the system at the very end of it. This system is very important for fighting meningococcal infections, bacterial meningitis. And that's why everyone who gets treated is vaccinated for meningococcus, to give you a head start to be able to fight these infections they develop. So that's really the main risk. And it's because this system is important for protecting the body from bacterial meningitis. Again, it's a relatively rare pathogen, but it's out there. So before I turn it over to Shreya, I'm going to try to confuse you even more. I apologize. That's a bit out of focus. And if you look at this and say this is confusing, that's the right response. Look at it simply as the same alternative pathway. There's the classic pathway and the lectin pathway. They get amplified for different reasons. The lectin pathway will respond to different sugar moieties on fungal pathogens. The classical pathway is kind of for the term classical, I think the first described, it's triggered by antibodies on antigens. So if you will, autoimmune disease, anything that triggers an antibody can trigger this pathway. And remember also the alternative pathway below, which is thought to be the bigger issue in atypical HUS. So this is a normal system. You need this. When it goes awry, that's when you can have trouble. And the reason it's important to show you this confusing slide is to show you the multiple targets. This is a paper from the Lancet from 2000. I forgot to reference, I apologize, from 2024. And it's already out of date in terms of molecules that are out there. There is a factor B inhibitor that's now approved by the FDA. I'm not certain about Europe, for treating PNH, a slightly different disease than atypical HUS. Have you guys heard of PNH before? And people probably expect you to understand that because you have this disease sometimes, just like they expect a hematologist is going to understand PNH. But I don't do such a good job with that. I do more of the atypical HUS. Best way of thinking about it is the PNH is a disease where the patients lack normal protective proteins on their red cell. So they've got a normal complement system, but it's their red cells that are abnormal and get lysed. And there's a few other things that happen. But that's something where they present with anemia called a hemolytic anemia, and they can do it very quickly. Very much easier to do a study in PNH because you can track somebody's hemoglobin. So these drugs have all been developed: eculizumab, ravulizumab, the anti-B treatment, the oral inhibitor factor B. These have all been studied in PNH first, and then they go into HUS next. So you have to be sure they can block complement activation, block the lysis or red cells. You can have one of these genetic changes and have a genetic change, but not get atypical HUS. Does that make sense to everybody? So it's got a varying penetrance. You can be born with one of these, but never get into trouble. You never have the right stressor or other factors that we just aren't aware of. Yes?
Do you have any percentages on that?
It's about 30%, we think. So meaning if 100 people get one of these genetic changes, 30 will get into trouble at some time in their life. So you can see why it's not such a perfect and great idea to say, I've got this genetic change, let's check the whole family. There are certain families where you see multiple people affected, and you want to be careful and look at that. But you also don't want to take one patient and check everybody in the family who might carry a genetic variant or mutation that might never cause them a problem. So it can create anxiety in patients, for one, especially if someone's not a patient. It can also create anxiety with your insurance companies you're going to apply for insurance. And just like anesthesiologists, if you make an insurance company nervous, you don't get what you're looking for. You don't get surgery, you don't get insurance. You can tell them till you're blue in the face that you have a very low risk of getting this disease. You still have a better chance of getting it than someone else who doesn't have it, and they're going to get the life insurance policy at a cheaper rate than you are. So there are reasons why you don't always want to know. Patient anxiety, family anxiety, and financial anxiety. You just don't want to know sometimes. We tell our patients, if somebody gets sick and it doesn't seem right, let us know. We'll look into it. So being alert for it, but not necessarily testing everybody all the time. And with that, I'll turn it over to my colleague, Shreya.
Hi, morning, everyone. You heard everything about complement-mediated TMA and the different treatment options available. Just a show of hands, how many of you have ever been on eculizumab, ravulizumab, or these options were ever discussed with you? Okay. Has anyone had recurrent TMA despite being on complement-mediated therapy? Had relapses? Okay, that seems right? I mean, that's what you would expect in complement TMA. If you are on complement mediated therapy, ideally you should not have any relapses, right, when you are continuing the therapy. So we wanted to discuss this particular case because it was very unusual. This was not one of those cases where you start complement mediated therapy and this patient responded. This patient continued to have recurrent episodes despite being on complement mediated therapy, just meaning that maybe there are things that we still don't know about TMA. Maybe there are still more research to be done in this respect. And maybe there are other genes that require different treatment options beyond complement-mediated therapy. So this was a patient I saw with Dr. Cataland a couple of years ago when I was doing a rotation with him. She's a 49-year-old female who was sent to us as a second opinion for these recurrent relapsing episodes of what seemed to be complement-mediated TMA. And presented kind of the same way, but the interesting part was she continued to have these relapsing episodes despite being on long-term complement-mediated therapy, initially with eculizumab and later on with ravulizumab. So this is kind of the history. So when we saw her was in 2023. So these episodes really started in 2005. So when she was in her early 30s. Kind of started the same way. She would feel nauseous, have some belly pain, and then start noticing petechiae, and that's when she would go to the ER. And labs would show, as you would expect in TMA, anemia, low platelet counts, and significant kidney injury to the point that she required hemodialysis and admission. Initially, back in 2005, when she was initially seen at a different hospital, Adams TS13 was never sent, so we don't really know what her Adams TS looked like. But the fact that she had, significant anemia, thrombocytopenia, and kidney injury, it was presumed that this is TTP, and she was treated with plasmapheresis, steroids. She started doing well. She responded to this treatment, so it seemed like this fit. And she would go home in a couple of days, and she would be off hemodialysis within a matter of few weeks. Then this happened again in 2007, treated the same way. Happened again a couple of years later in 2011, treated the same way. 10 years later, when this happened again, this time around, Adams TS13 was finally sent. And interestingly, it came back normal. And that's when they thought that maybe it's not TTP, maybe she has complement-mediated TMA and we need to treat her differently because she continues to have these relapsing episodes. And this time around, she was started on complement-mediated therapy with eculizumab. Unfortunately, despite being on eculizumab, she had recurrent episodes 5 years later in 2020. And at that time, she was transitioned to ravulizumab just to see if, rather than eculizumab, will ravulizumab work in a different way? Will she respond to it? And unfortunately, despite being on ravulizumab, a year later, she had another episode. In 2019, at some point, she also had a stroke. We don't have a lot of information about that. We don't know what kind of treatment she got, but this was an outside hospital. But we think it might be related to this history of TMA because we know strokes can happen in patients with TMA and TTP. What were the interesting things about this patient? One, she would have recovery of her renal function, almost complete recovery within a matter of few weeks, without needing any complement-mediated therapy, right? Which we know in patients who have complement-mediated therapy, truly you need to start some kind of complement-mediated therapy to help them recover, to help their kidneys not get bad. But this patient had complete recovery. This patient also had 2 pregnancies in the meantime, and she did not have any TMA episodes at that time, which is also unusual, right? Usually you expect in patients who do have TMA and TTP, you worry about an episode during pregnancy, and this patient did just fine. And then because this patient, was not really responding to complement mediated therapy, we wanted to know what was going on and what can be done. So far, there were no complement studies or genetic testing that was done. So at this time, when she decided to see us, we sent complement gene testing. And the genetic testing came back positive for plasminogen gene mutation. Has anyone heard about this gene? Okay. So plasminogen gene mutation, we just don't know a lot about this. This is a coagulation gene. This is not one of those complement genes, so it acts somewhat different, but there is not a lot of data out there on how this gene mutation impacts patient with TMA and how do we really treat it. And the reason I mention this is because plasminogen really does not have any role in the complement pathway that we have been talking about since this morning. Where plasminogen plays a role is your coagulation system. Whenever you have a bleed, your blood starts clotting. It forms a clot so that you stop bleeding. And so that you just don't form too much of a clot, there's also a mechanism to break down that clot. And that's the role that plasminogen plays. It breaks down that clot after, the bleeding stops, really. If there is a mutation in this plasminogen gene, you can think about it this way, that maybe this clot is just not breaking down and this patient is having too much clotting, meaning too much of thrombosis. And that may be the reason why these patients are having thrombotic microangiopathy, which is unrelated to their complement system. At least that's what we think is going on. And because of that reason, we think that maybe this patient will not respond to complement-mediated therapy, and what you should consider doing is a blood thinner, right? Because you don't want these patients to continue developing these blood clots. And that's what we thought we'll do for this patient. So we decided to start this patient on a blood thinner, and it's been almost 2 years, I want to say, and so far has not had any recurrent episodes. So this is just to keep in mind that, there may be something beyond just the complement pathway that can cause TMA, which will not respond to complement-mediated therapy. And that's why doing these genetic studies are really important to understand what should be their treatment that will help this patient.
So does that patient still have complement-mediated TMA?
So we think it is other TMA, which is probably coagulation-related TMA and not complement-mediated. Yes. So I think 2 years later, Dr. Cataland saw another patient who had a similar story. This was a patient that was referred to him by another colleague, and kind of a similar story. This patient continued having these recurrent relapsing episodes of TMA, normal Adams TS13, was seen by so many different people. They don't really know what was going on. Was it complement-mediated TMA? Was it TTP? Was it something else? But, Adams TS13 always came back normal. So for this patient, again, Dr. Cataland ended up sending gene testing. Just to add to this patient, I think the record stated that this patient had CD46 or MCP mutation. This is another mutation where patients kind of behave the same way. They'll continue to have these recurrent relapsing episodes, and they recover on their own. But when we checked the records, we could not really find this mutation testing. And that's why we ended up sending testing again. And interestingly, there was nothing found in the CD46 or MCP mutation. So we didn't really find this mutation. So I'm glad we sent this testing. And what we found was a mutation in plasminogen. And these, as you see, many of these mutations will say variant of unknown significance, because the fact is we just don't know enough about these mutations. So majority of these times, they will just show up as variant of unknown significance. And it's up to us to decide based on the clinical history if this truly might be pathogenic. So, going by all this, Dr. Cataland and I was just talking about, why do we have more patients who have this plasminogen gene mutations? Do we need to do something else for these patients? There is, at OSU, they do maintain a registry of all the patients that Dr. Cataland has seen over the years who have had TMA and TTP. So we looked at all these patients who have had TMA, and if they had genetic testing done, and were there any patients with plasminogen mutations. So I think we had a total of 120 patients in this registry who had presumably complement-mediated TMA. about 50% of them, genetic studies did not find anything wrong, which is what happens half of the time. There are no genes identified, which would be related to complement-mediated TMA. In the other 50%, we did find some abnormal gene that would explain their TMA. And in 5 of them, sort of, it's still 5 out of 60. So it's still a low number, but we did find 5 patients who had plasminogen gene variant. Interestingly, all these patients were female, and their first episode was in mid 30s to mid 40s. All these patients have had pregnancies in the past and did not have any TMA episode with their pregnancy, which is also interesting and very different from the usual complement-mediated TMA. All of them did have thrombocytopenia, hemolysis going on, kidney injury to the extent that some of them did require hemodialysis when they were initially diagnosed, but they recovered within a couple of weeks to months. Either they got complement-mediated therapy or they didn't get eculizumab. Either way, their kidneys totally recovered. So based on this, we were not sure if complement-mediated therapy really works for these patients. So 2 of these patients at this time are now on blood thinner, just because of the fact that we think plasminogen mutation plays a role in coagulation pathway rather than complement-mediated pathway. And so far, those 2 have not had any recurrent episodes. So really, I think we need to learn more about these mutations, plasminogen mutation in particular, because we just don't know enough about this mutation. And if truly you can avoid treatment with eculizumab in these patients, why not, right? So I think with that, I think we still have more to come. But if you are one of those patients, or if you know anyone who has had these recurrent episodes who have not responded to complement-mediated therapy, this is something we should think about. And with that, I think there was one more patient or one more case report that we wanted to mention that was done by Nishant Tiwari. I think he's here. He worked with Dr. Cataland too and reported the same thing, which happened at OSU in one of their patients, or not OSU, Oklahoma. Louisville.
Look at the date. It's interesting to show you. Before you think we're so smart up here, this is 2021. So a lot of these things take recognition and time. So when I saw that first patient who was from Oklahoma City, it didn't make sense. Then we see the second patient, and then it starts to come together. Now Nishant had sent me this paper shortly after it was published, and I read it, and I thought, oh, that's interesting. But it didn't register. Once I see the second patient, I had to look through his CV for a different reason. And I saw this paper, and I thought, wait a minute. This is exactly what we saw. So it's a good example. You have to sort of see things in the right light, in the right context. So you can read something and not be thinking properly or correctly or accurately. It's not wrong, it's just different. So learning is a lot of it's repetition. And it took seeing this happen a couple of times before my eyes to say, this doesn't make sense. It started to make sense. And I read Nishant's paper again on a Saturday morning as I walked to the hospital, and I thought, holy shit. That's exactly what we saw. So I called him up. I sent him a text. I said, send me another copy of this paper. I got to look at this again. And that's indeed what we saw. So he reported the same exact thing. If you read his paper, it says, we thought this was TTP, but it didn't fit. And he took the next step of thinking about it and taking the next step and writing this up. And this is kind of how this happens in research. It's not just all of a sudden it all develops and it's published. It's that multiple people seeing it. Because you want to see 2 different people see the same thing to say it's an objective finding. And when the 2 different people are seeing the similar type of thing, it tends to make more sense. And people will also tell you this isn't true, this is not reported before. Well, it's got to start somewhere. And I think what Shreya is involved in is a research project to expand the search for these plasminogen variants throughout all of our sites. Because this is a rare thing. We found 5 at Ohio State. But you involve all of our consortium sites collaboratively. I think we're going to find more of these. And that's some of the work she's doing in the research grant she's going to be writing here soon to try to better understand. Because these patients get called TMA or atypical HFAS. And they get that label. It's not necessarily yes.
Curious about the complement functional panel. Do they have any activation of complement panel in?
We don't routinely use functional panels since it's sort of difficult to sort of interpret it. So I don't know. But most of these patients had active infections, well, they both had active infections, which should activate Yeah, it's interesting. Yes.
How would I go about to ask my hematologist, nephrologist, all my whole team, my cardiologist? Aside from sending them this article and saying, hey guys, do you think this would be me?
You know, I think the good way to start would be just asking them, can we do genetic testing?
We have.
Okay. Usually plasminogen gene is included in the gene panel that was sent. Also, I don't know when it was sent because, you know, as we learned in the last talk too, there are things that we learn more over time. So if your gene panel was sent like 10 years ago, maybe the plasminogen gene was not included in that panel. And maybe now, if you do it, that might be. So I think just looking at what the genes were tested and if these genes were included or just asking for a repeat would be a good way to start.
If you think how these things got evolved over time, it'll make more sense. We think everything is perfect along the way. But these patients were, this is an AHUS panel we get from the University of Iowa. Richard Smith does it. Years ago, there were reports of TMAs, and people did genetic studies and reported a TMA, right? This picture, and they found one of these mutations. So because of those mutations and that broad picture of TMA, it got lumped into a possible genetic variant. And that's why it's in the renal panel. Richard Smith is a smart guy, and that's why he sort of separated out that genetic variant. And we're going to be working with Richard as well to clarify other awards. So it's the way it was lumped in initially, just like TTP and AHUS were lumped together as TTP and AHUS because it didn't matter. You didn't plasma exchange either way. Well, now it does matter. When you find something different, this is why I think eventually with Shreya's work gets set off as something different. If somebody has a lower platelet count than normal, you're going to think about this maybe as the last.
So just to be clear, for the people that are in here, the reason you first asked the question, has anyone relapsed even though they're on drug, is because if you're doing well on your treatment, we think you have the typical complement TMA. It's only for people who that drug isn't maintaining what they're supposed to do that maybe they should look for an alternative condition, correct?
Yes and no, because I think our first patient, when we talked about her, I think initially she was not getting anything, you know, for the first 3 episodes. She was being treated as per TTP and she recovered just fine. So I think 1, if you're not responding to complement mediated therapy, 2, if you continue having these recurrent relapsing episodes, that's when you should think about this mutation.
I just wanna make sure that people aren't just gonna run to their doctor.
Yes,
You
yes,
know, so if they're doing well,
right,
then just stay the course.
exactly.
What got our attention was she was having episodes despite blocking her complement system. That's not right. That didn't make sense. That was if you're responding to it, that's a completely different thing. Right.
Yeah.
But if you're not doing
Right.
well.
Right.
But you think about what happened to her episodes when she was treated in Oklahoma City. They thought it was TTP. What they give her? Plasma. And what's in plasma? Plasminogen from blood donors who gave plasma. So they got better. They get better with treating the infection. They got better with she got her plasma. They were actually treating her and they didn't even know it. But that shows you, as you learn more, you can understand more what you're doing. There's actually a plasminogen or comment you can give patients as well. So again, it's sort of the general to the more specific. So I think eventually we'll see that we're going to have another bubble for a plasminogen or coagulation. And there's other things that have kind of fallen out over the years as well. And it happens sort of like this in a way. It doesn't make sense. That's when you scratch your head. You can look at something different and physicians can say, oh, that's just a rare presentation of a more common thing. And that's one way of looking at it. But then you see it twice and you say, it's something else maybe when you just have to throw a logic in. It doesn't make any sense.
But I still want to emphasize this is one of the rarest. So the more common would be a complement mediator and usually responds to complement blockade therapy. This is one of those rare ones in case they don't respond to anything and are breaking through all these treatments.
Yeah, I mean, it's science, but it's also, if you will, pattern recognition. You think things don't make sense. And again, when I saw that woman, this doesn't make any sense. You're scratching this doesn't make any sense. Then you kind of look a little further and see somebody else do the same thing that you did. That starts to do something. That's kind of how the process starts. It's not all at one time. Somebody did one thing at one time with one patient. It's sort of an evolution of things. And people over the years have been told many things every now and then. were true that people said many years ago and things that were false that people said most around. Sometimes the longer you say the same thing over and over again, even if it's wrong, people will believe it's right. You see that? You guys like that? My wife told me.
Other questions? Otherwise, I think we can
Yeah.
stop early. Thank you, guys.
I don't know if this is, I'm just curious about DGK in an adult. Could it cause something?
She'll see that more than I will, but that's also another genetic variant. Diethylglycerol
Epsilon, yeah.
It's a very rare condition that presents like a TMA.
Usually in childhood. Yeah.
Shouldn't see it in adults. This is one reported case. Yeah. Very good. Well, thank you all for your attention.
Hang on, I'm taking pictures. I gotta act like you're talking. You're definitely throwing. Best talk ever. No, there's a break, yeah.
So it's 3 times.
Yeah, you have till 11:10.
Three, 2, 3, 7. Yes.